So now we're done with the overall diagnostic approach to leukemic patients. Now let's talk a little bit about the overall treatment approach. Before really jumping into each specific leukemia, I want to give you a general idea how leukemia is treated. And there's certain common ground between all kinds of leukemia that help you understand treatment. In the most general sense, treatment of leukemia is like a scale. And a scale is all about balance. Leukemia treatment is about a balance between aggressive treatment and less aggressive treatment. What do I mean by that? Aggressive treatment is normally done for acute leukemia. Okay, if you have a patient with acute leukemia, they often need aggressive chemotherapy in order to control their leukemia. Although acute leukemia generally gets treated with aggressive chemotherapy, the molecular subtype of the leukemia matters a lot. In the age of modern and personalized medicine, we look at gene mutations and chromosomal translocations in order to make a prognosis and come up with a specific subtype of leukemia that needs a specific treatment. Less aggressive treatment. Chronic leukemias are normally not as aggressive as acute leukemias, and they get a less aggressive treatment approach. As well as less aggressive molecular subtypes again. Not every leukemia gets treated the same way. Just because it is AML, it does not mean the patient gets exactly the same treatment as his neighbor who also has AML. Okay, they might have a very different genetic subtype. And then, apart from the leukemia, what also matters a lot in hematology and oncology is the patient himself. Not just the disease, but looking at the patient. Looking at your host. Aggressive treatment is reserved for young patients, patients who are less than 65 years of age and have few comorbidities. Okay, so not a patient who has heart disease, COPD, obstructive sleep apnea, and another cancer. Okay, this is not an ideal candidate, in particular if this patient is also old. Chronic leukemia, again, greater 65, poses a major challenge in leukemia treatment because they are often not fit enough for aggressive chemotherapy. Patients with many comorbidities, similar. So, in determining what treatment a patient needs, what we want to do is we want to define is this acute or chronic leukemia. We want to go down to the specific subtype of the leukemia, all right, to really offer personalized medicine. And personalized medicine also means to take a step back and look at the patient overall, separately from the leukemia that probably was the reason for admission, but it does not define the patient as the host overall. Okay, we want to see is this a young patient or an old patient? Is it a patient with few comorbidities or many comorbidities? Okay, let's get a little bit more specific. Let's define the overall treatment approach for patients with acute leukemia and chronic leukemia. We're going to talk about AML and ALL, as well as CML and CLL. And again, they are very different in terms of how aggressive you treat those patients. AML and ALL patients. All of them get induction chemotherapy, okay? And that's often a similar regimen of chemotherapy. There are slight differences, but a lot of them get treated with similar regimens, and we're going to get to that in a second. Induction chemotherapy is normally quite aggressive chemotherapy, attempting to control the patient's disease burden. After finishing induction chemotherapy, we want to check whether the patient has a complete remission. And we're going to look at the bone marrow, do a biopsy again, and see are there any blasts left. If there are blasts left, so patient doesn't have a complete remission, we go back and give the patient again induction chemotherapy. The main goal for your treatment for AML and ALL early on is to achieve a complete remission. Okay? If you are not able to achieve a complete remission, you have to go back to induction chemotherapy. If you're able to achieve a complete remission, what's next? Are you done? That's actually a good question. When patients first got started on chemotherapy for AML back in the day, they had dramatic responses after induction chemotherapy. They were amazed how quickly they could clear a patient's bone marrow of their blast cells. But then, after not giving them more chemotherapy, almost all of those patients eventually relapsed. And that led to the principle of post-remission therapy. Okay, all patients with AML and ALL need some sort of post-remission therapy. You can't just leave them there after they achieved a complete remission because they're gonna relapse at some point. What post-remission therapy you give them is highly specific and depends on the patient as well as the molecular and genetic subtype. What do I mean by that? We want to see, is this a good prognosis leukemia or a bad prognosis leukemia? For the good prognosis leukemia, we normally do more chemotherapy, either consolidation or maintenance chemotherapy, depending on whether you have a patient with AML or chemotherapy. This is a relatively less aggressive type of therapy. If it's a bad prognosis leukemia, we do the most aggressive therapy that we have, called bone marrow transplantation. And again, this differentiation between good and bad prognosis is a difficult one and really takes an expert to understand it. We're going to talk a little bit about it when we get to AML, about how to sorting out whether it's a good or a bad prognosis leukemia. Okay, so let's talk about the chronic leukemias next, CML and CLL. Again, in CML and CLL, we have good prognosis subtypes and bad prognosis subtypes. Good prognosis subtypes get normally chemotherapy. Bad prognosis subtypes need more aggressive therapy. CML. Good prognosis is chronic phase. Remember those patients who have less than 5% blasts or less than 10% blasts, or between 10 and 20 would be accelerated phase. Those patients get tyrosine kinase inhibitor based on the translocation that they have between chromosome 9 and 22, which codes for a tyrosine kinase, BCR-ABL. Poor prognostic subtype is plastic phase CML. Okay, CML that actually converted into AML has now more than 20% blasts. Okay, they still get a TKI, but they also get treatment, aggressive treatment, like an AML patient would get treatment. CLL, good prognostic subtype, and we're going to talk about a little bit what that means. They can normally be watched often, even without chemotherapy, or if you feel they're more close to an aggressive subtype of CLL, they get chemotherapy. Aggressive subtypes of CLL, in particular after they transformed into ALL, get treatment like ALL. Let's talk a minute about the most aggressive form of treatment we have in leukemia medicine is bone marrow transplantation. What's the idea behind bone marrow transplantation? The idea is to give high-intensive chemotherapy or total body irradiation as a conditioning regimen to eradicate all leukemic stem cells. What does that mean? Remember those patients who had a complete remission, didn't get any consolidation chemotherapy or stem cell transplant? They all relapsed. Why did they relapse despite getting intensive induction chemotherapy? Well, the reason is that there are leukemic stem cells that lie dormant, they don't proliferate rapidly, and they don't get killed by chemotherapy on the first attempt. After stopping chemotherapy, they're able to repopulate the marrow and make leukemic blasts. By giving patients intensive chemotherapy or irradiation and completely wiping out the entire bone marrow, you basically try to get rid of those cells. And then you give them donor cells in order to rescue the bone marrow. Because after you wipe out the bone marrow, you basically don't have any red blood cells to transport oxygen, no white blood cells to fight infections, and no platelets to stop bleeding. So you need to reconstitute the bone marrow. Early research into bone marrow transplantation actually had quite some surprises on the way. One of them was that patients with a transplant from a sibling have a better outcome than transplants from a twin. That was surprising. Normally, if we think of transplants, we want the donor and the recipient to be as close as possible in their genetic makeup to prevent side effects of the transplantation. That was not true for hematopoietic stem cell transplants. The siblings did better than the twins, who have the entirely same genetic makeup. Why is this? It's a good question. That brought researchers to the idea of graft versus leukemia effect. Okay, what is graft versus leukemia effect? Let's go on this illustration. So you have a T cell of your donor, and you transplant this T cell into a bone marrow of your recipient. There's still some leukemic stem cells in the bone marrow, and those get recognized by the T cells that you transplant. Those T cells kill those cancer cells then and eradicate the leukemic stem cells, indicated here as blasts, eradicate those cells and prevent relapse of the leukemia. If you have a donor that's different in the genetic makeup, the probability that the T cell is going to recognize leukemic cells is higher. The problem is there's a flip side to this coin, okay? And it's called graft versus host disease, because those T cells also recognize antigens on normal cells, in particular the skin, intestines, and liver. And they lead to an effect called graft versus host disease. Okay, so patients have dermatitis, they have severe diarrhea, and they have problems with their liver. I always like to think of those as a flip side of a coin. Okay, you get positive effects from graft versus leukemia, but you get negative effects from graft versus host disease. And graft versus host disease can be a very severe disease. So how do you pick the right donor for your recipient? Let's plot those. Okay, on the x-axis, we have increased risk for relapse, and on the y-axis, we have increased risk for graft versus host disease. Let's start again with our twin donor here. Okay, so they generally have a very low risk for graft versus host disease. Okay, their T cells do not recognize normal cells as foreign cells because they basically have a similar genetic makeup than their own normal cells. But they have a huge risk for increased relapse because they also do not clearly recognize leukemic stem cells. If you would pick a completely unrelated donor, you would have a low risk for relapse because you recognize a lot of leukemic stem cells. But unfortunately, you also have a high risk for graft versus host disease. So you have skin disease, liver issues, a lot of diarrhea, and all those terrible side effects. Kind of in between is an HLA identical sibling donor, okay, which is your ideal donor. Does recognize some leukemic stem cells, but also doesn't have the highest risk for graft versus host disease.